So, good morning. Good morning. Thank you for coming so early. My name is Anthony Patterson. I'm the Assistant Director of Nursing at Queens Hospital Center, Behavioral Health. I'm here with Scott Levine, Staff Nurse, Queens Hospital Center, the Chairman of Behavioral Health Site Council, and Shared Professional Governance. Today, we'll be sharing our presentation and implementing a standard Clozapine-induced constipation nursing protocol in patient settings. We will be sharing the protocol we put in place after a critical patient safety event and our outcomes since the protocol's implementation. We have no financial relationship to disclose, and there is no discussion of off-label use. Our learning outcome is that by the end of this presentation, you'll be able to demonstrate knowledge of nursing-led Clozapine constipation prevention protocols by identifying key components and their role in improving patient outcomes. The key takeaways are Clozapine-induced constipation poses a significantly greater mortality risk than other possible adverse effects, yet it remains under-recognized, under-monitored in clinical practice, particularly on inpatient units where the risk is higher. Our second key takeaway is that Clozapine-induced constipation is preventable through nursing-led interventions that promote hydration, ambulation, a bowel regimen, and patient education. So, with that, I'm going to pass it over to my colleague, Scott Levine, to discuss why this protocol is so important.
Hi everybody, my name is Scott Levine, and I'm the Behavioral Health Chair at Queens Hospital Center for the Behavioral Health Department. So, thank you, Anthony, and good morning, everybody. Clozapine currently is the gold standard for treatment-resistant schizophrenia, but it's often underused due to the potential adverse effects. Most well-known would be agranulocytosis. But the one we're going to talk about today is gastrointestinal motility. It's too often overlooked, and slowed motility can affect up to 50 to 80% of patients taking Clozapine. Sometimes those patients experience slow motility, but they present with little to no symptoms. It's also very common for them to underreport their symptoms. Severe outcomes, including bowel perforation, ileus, and sepsis, have occurred in Clozapine-treated patients without any preceding symptoms. That silent progression means that just waiting for complaints of constipation is an unsafe practice. You need to do proactive daily assessment and prevention, including hydration, ambulation, bowel regimen, and documentation. They're all essential to detect the risk early and avert a catastrophic complication. We actually experienced this firsthand on one of our inpatient units, which prompted us to create an evidence-based protocol to prevent any further Clozapine-induced gastrointestinal hypomotility, or CIGH, complications. So, as I mentioned, the most widely recognized potential adverse effect of Clozapine is agranulocytosis. There are currently 5 black box warnings that the FDA has put out for Clozapine. They include agranulocytosis, myocarditis, seizures, orthostatic hypotension, and mortality of elderly patients with dementia-related psychosis. Notably, constipation was completely left off and not listed. The FDA did strengthen their warning, but it never elevated it to black box status. That was in 2020. There was the Clozapine REMS program that was initiated in 2015, and it mandated that healthcare providers report the results of absolute neutrophil count, or ANC, blood tests prior to pharmacies dispensing Clozapine. This requirement was discontinued this past February of this year in an effort to reduce barriers to the utilization of Clozapine and increase its usage. As I mentioned, it's being underused for the effectiveness of it. But once again, clozapine-induced constipation was neglected. Clozapine may have, or CIGH rather, may have a mortality rate of up to 10 times higher than agranulocytosis. Nevertheless, many inpatient units have not implemented a standardized protocol to prevent it. Constipated-related complications may account for up to a 12% relative mortality rate in clozapine-treated patients globally. So as I mentioned before, we did have a critical safety event. First thing we did after that was to create a multidisciplinary team and do a root cause analysis. Then the team reviewed our procedures, examined the existing literature and guidelines, and developed an evidence-based protocol. Our frontline staff piloted the program, and through a few PDSA cycles, we refined it to its present iteration, which we'll go over. So what are the key elements? So our nurses do daily abdominal assessments, including inspection, auscultation, percussion, and palpation to detect early signs of hypomotility. Now, this is one of the most important steps because we found in the literature that relying on self-reporting of bowel movements to be very ineffective at discovering CIGH. Now, as psych nurses, before this, we were doing little in the way of focused medically related assessments. So we asked our nurses to dust off their dusty stethoscopes. Next, we encourage fluid intake throughout the day by proactively offering water and juice and subjectively documenting whether the patient has been effectively hydrated. Hydrating is an obvious but easy and important component of reducing hypomotility. We also encourage ambulation throughout the day to promote motility. We often ask them to walk with us as we do our shift assessments and spend some time actively listening to our patients. We track the patient's bowel movements on a shift-by-shift basis with a 48-hour limit before we prompt the provider. All clozapine patients, unless there's a contraindication, should be put on a bowel regimen by the provider. Whether it's a stool softener or a laxative, there should be an order placed on day one. Our patients are ordered high-fiber diet to support their bowel health, and our patients truly, truly love the food. Okay, no they don't, I'm just kidding. But we do the best with what we have. We maintain a written handoff book, which includes a report on each patient for shift changes. The log includes a section indicating whether a patient is on clozapine, and if they are, we document their ambulation, hydration, bowel movements, and the results of the focus assessment during handoff. So far, we've kept it low tech, and we have a written unit clozapine logbook. So each clozapine patient has a row. Each shift, the initial, that the completion of each step in the bundle happened. And throughout their inpatient stay, they're educated on clozapine and constipation, and this is reinforced upon discharge, and the completion of education is documented in the logbook. We also have a designated board in the nursing station that prominently displays a list of all patients that are currently being treated with clozapine. The charge nurse verifies that the nursing staff members who are directly involved in their care have accurately documented all relevant information. So what are the outcomes been at our hospital? I'm proud to say so far, we've had 0 transfers required for constipation since the established protocol. According to the logbook, we've had 32 patients from June 24 to June 25, and across 173 shifts, we had a 100% compliance rate for the required interventions and documentations. Most importantly, we had 0 reported cases of serious CIGH-related morbidity. All right, so where do we go from here? What's the next steps? What is the future of this project? We're in the process of trying to expand our access to the other hospitals in the New York City Health and Hospitals family New York City Health and Hospitals happens to be the largest municipal hospital family, and sharing means caring. We're looking to digitize the logbook into the EPIC electronic health record for easier compliance tracking. We'd like to continue our staff education and provide refresher courses for current nurses through competencies. We'd like to evaluate this project over a longer term, and we've been collaborating with CPEP and the outpatient services to ensure that the patients are receiving care at our hospital equally and they receive the same preventative approaches throughout their care continuum. All right, let's see if we met our learning objective. So if you haven't joined our game, I'll give you another chance here. You can scan the QR code, or you can go to kahoot.it and put in the game pin. I'll give you guys like a minute or two. Is anybody still trying to get in? We ready to play? So the prize today is a $15 Starbucks gift card. All right. I really like the Halloween theme there, right? All right, so we're starting. Preventing clozapine-induced gastrointestinal hypomotility. True or false? The absence of bowel sounds is sufficient criteria to begin the clozapine constipation protocol. Okay, it's a tricky one, it's false. That's because the protocol is initiated proactively for all clozapine patients. Absence of bowel sounds may indicate risk, but it's not the sole criteria. Okay, another true or false. Agranulocytosis is more common and more deadly than clozapine-induced gastrointestinal hypomotility. There you go, Jenny. Good job. CIGH is more prevalent than agranulocytosis and may have a higher mortality rate of up to 10 times higher. Yet it's not included in the black box warning and remains inconsistently monitored. Which best reflects the primary focus of the clozapine GI safety protocol? Okay, yes, proactive prevention of gastrointestinal hypomotility. The protocol is designed to prevent GI hypomotility before symptoms emerge through structured nursing interventions, not reactive symptom management or lab monitoring. Which statement about clozapine-induced gastrointestinal hypomotility is most accurate? Clozapine-induced GI hypomotility can progress without symptoms and has caused fatal outcomes such as ileus, perforation, and sepsis, even in patients who never reported constipation. Which patient behavior may falsely reassure staff during the early stages of CIGH? Good job, Biscuit, 5 in a row. Patients may report having bowel movements even during early or partial obstruction. Nurses must assess patterns and perform physical exams rather than rely solely on patient self-report. Select all that apply. Which of the following are true regarding CIGH? Okay. That's double points. So CIGH may progress silently and cause life-threatening complications. The FDA strengthened warnings in 2020 but did not issue a black box. Nursing protocols can improve early detection and prevention even without formal REMS monitoring. Double points. Which of the following are components of the Clozapine constipation prevention protocol? Select all that apply. Protocol emphasizes daily assessments, hydration, ambulation, and dietary fiber. Ultrasound and delayed Biscuit-A are not included and may miss early signs of hypomotility. Prevention, not reaction, is the key. All right, let's see who's in third place. Biscuit. Second place. And the winner is Jenny. All right, now references. All my images were created on AI. I thought that was pretty cool. All right, so I'm opening up to questions or comments. If you have questions or comments, please use the microphone.
Hi, I'm Erin. I'm a clinical nurse specialist from Colorado. Did you have any issues with provider buy-in in establishing getting this ordered on admission?
So we didn't have trouble with provider buy-in. A lot because of what happened, it became clear. The nursing buy-in was a little tougher because now they're doing the abdominal assessments, but we involved nursing the whole way. We took the lead as nurses and helped create the protocol, and I think when the people who are the stakeholders are involved in the creation of the protocol, it helped.
I was wondering about your assessment on admission, and does that include an assessment of the history of constipation, last bowel movement? I know it's subjectively reporting, but is that part of your initial assessment on admission, even prior to maybe the initiation of Clozapine?
Yes, so usually that would happen either in the psych emergency room or the medical ER, but yes, that definitely does happen, and then it's redone upon the admission to inpatient. So there's 2 times we ask about it, first in the psych emergency room and then when they get to the inpatient unit.
Good morning.
Hi.
My question is, what would be the protocol or your recommendations for an outpatient clinic that provides Clozapine to the patients?
Education. Since I've had this project, we have created a flyer that we hand out to every single patient that is on Clozapine. We have it in about 12 different languages, and every patient that's out in our outpatient that gets Clozapine is educated on it. But that's a great question because it's very, very important.
And sometimes we have difficulty because some of our patients cannot read.
That can happen too, but that's verbal education too. One of the assessments that we always do is their learning style, right? Do they like to learn by reading? Do they like to learn by demonstration? Do they like to learn verbally hearing?
Thank you.
No, thank you.
I wanted to know about EPIC, use in EPIC.
Yeah.
To the flag, and how are you setting it up now with your IT?
We're trying to work with Epic. We have some Epic super users, and we're trying to work it in to the protocol so that there will be flags for the providers to see, and also for the nurses. And that right now we're documenting in the logbook. We'd like that all to be in Epic and a little more, modern.
I mean, how long have you been working with trying to?
It's more recent that we started working with Epic to do it. I mean, we were piloting it, and we wanted to get it going for 6 months first, making sure that we're getting everything. We did the PDSA cycles, so it's more recent now that we're working with Epic. That's kind of what we're doing with it now.
Is there any way we could get a copy of your protocol, like your handout or pamphlet?
The pamphlet for outpatient? Sure. At the end, I'll give you my email address. And,
Thank you.
Okay. Thank you all very much. I appreciate it.